Hi, I'm Vishal Kishore, and I'm the Director of the Health Transformation Lab and Professor of Innovation and Public Policy at RMIT. Now, here at the lab, we aim to provocatively and rebelliously transform healthcare, playing with breakthrough technology, innovative and wacky ideas, and the most inspired and interesting people. My own interests lie in healthcare cybernetics, political economy, and the ethics and public policy of healthcare systems. But if you think that's interesting, just wait until you meet the rest of the team.
Lecturer in the School of Design and fellow in the Health Transformation Lab. I work creating living labs for social innovation in healthcare organizations.
Hi, I'm Charlotte Fligner and I'm an Innovation Fellow at the Health Transformation Lab. I bring my background as an architect and also in design anthropology to the lab's strategic design and innovation work.
Hi, my name's Jess Chatterton and I'm an Impact Fellow here at the lab. My background is in biomedical research as an immunologist at the Doherty Institute. My interests are sustainability, systems thinking, and science communication.
Hi, my name is Nicolas. I'm a development economist originally from Argentina. I work as an Impact Fellow researching issues in the intersection of economics, public policy, innovation, and political philosophy.
Hi there, my name is Govind. I am an Impact Fellow here at the lab. My background is in data science, and my interests lie in the different ways we can facilitate human flourishing and cybernetics and its feedback loops.
Have your video up. So welcome everyone. Thanks so much for joining us. This is our third online Open Lab event. I'd like to acknowledge the people of the Kulin Nations, on whose unceded lands many of us live and work while we meet today. I respectfully acknowledge their elders, past, present, and emerging. So my name's Jessica Chatterton, and I'm an Impact Fellow here at the lab. I'm just going to do some brief introductions and then a little bit of housekeeping, and then we can get started. So as a lab, we're seed funded by Cisco and based at RMIT, and we aim to, if I can steal Dr. Vishal's favourite words, transform healthcare through provocative and rebellious thinking. We love playing with breakthrough technology and innovative and wacky ideas and inspired and interesting people. We aim to be the home for healthcare's most wicked and complex problems and a place where we can have discussions that no one else is having. So this brings me to today's event, where you're going to hear about some fascinating research done by Gobind Singh, who is another one of our Impact Fellows. He's going to present some really cool examples of dynamic health spaces, and that is hospitals and healthcare services that have been designed with the capacity to adapt and evolve in times of need such as this, a pandemic. So as I mentioned already, we've got a slightly altered format from the last two events. We really want to encourage some conversation, and we used to run our open labs in person, and we really enjoyed meeting everybody and learning from the guests that we had come in. So today we want to hear your ideas and your experiences. So if I can ask all our guests, if you can introduce yourself in the chat, that would be amazing. Just your name and where you're from or how you heard about us. If you'd like to ask a question, feel free to speak up. Or you can put your hand up, which is the little small hand symbol next to your name in the participants window above the chat. Or you can post questions in the chat if someone's currently speaking. If you're not speaking, please mute, just so that we don't have noise interference, but leave your cameras on. We'd love to be able to see your faces. And if you aren't muted and your mic is picking up noise, we might mute you just to save that interference. I think that's about all. So unless anyone has any questions, I'd love to hand over to Gobind to start sharing some of the research he's been doing. Thanks, Gobind.
Hi, thanks, Jess. It's really nice to be here today. I mean, even though we're all in our own houses, we still get to facilitate this conversation. And I think this is actually one of the favorite parts of the job that we do at the lab. Well, it's a virtual lab in this case. But the conversation we'll be attempting to curate today or cultivate today will be about learning from the pandemic and looking into the future. And it's how we can create health spaces for that plan to change and how they can move dynamically through different environments. I like this group that I can see on my screen right now. It looks like we're a curious bunch that have come together to catalyze ideas in each other's heads and minds. But coming back to the topic for today, all of you probably already know this spiel, and it's that the pandemic has come and hit our social and health systems, as Nicolas says, like a jackhammer, and it caused all sorts of cracks. And as Vishal says, only a relatively small percentage of the global population has actually contradicted COVID, but entire populations are already affected and displaced and impacted by its consequences. And to diminish the spread, what's currently in place is physical distancing. And that's the conscious effort to reduce close contact between people to flatten the curve. But that's where we sort of pause. Why do we need to flatten the curve? We flatten the curve so that our health systems are not overwhelmed. But what if we can create a system that does not get overwhelmed? What if we can create health systems that have the capacity to allocate this surge whenever it comes in? And that's what we might hope to discuss today. And there's this common quote that's often attributed to Darwin, but it was actually Leon Magenson who said it, and it goes something along the lines of, it's not the most intellectual of the species that survives. It's not the strongest that survives. It's the species that survives is the one that's able to best adapt and adjust to the changing environment which it finds itself. Our health systems, as opposed to that, have become rigid. And in this rigidity, there's a lot of constriction in uncertain times. And what's curious is that everything about this pandemic has been a function of a past set of choices. The question now is, are we adapting in a time of crisis? Now, there are numerous examples of dynamic adaptation happening all over the world. And with some of it's not necessarily spurred by COVID, but let us take a look at this little presentation I made. Can everyone see this? Just nod your head. Cool. But yeah, this was the quote that I shared just now. And if we think about our health systems, rather than ending up having to MacGyver them as we face adversity, let's take a look at what's happened around the world. So the way we could cut dynamic health systems is, for one thing, we can make current healthcare spaces more dynamic. Another, we can turn healthcare spaces turn non-healthcare spaces into healthcare spaces. And finally, we can make healthcare spaces mobile. So this is what happened in the UK. They had a convention center, and because they anticipated so much more coronavirus cases as a result of what was happening in Italy, they opened up this hospital, which they called the NHS Nightingale. It was created in a convention center, and it was initially set up with 500 beds, and it could expand and contract as they saw fit. But what happened was, because of the relatively low usage, they've decided to disband it. But it was in response to the anticipation of the increase in the number of cases that they set this up. But this was in response to the hospitals not being able to possibly cope with the uptake of cases. Some of the other examples we found is we can also mobilize health spaces. Over here, Cisco has created a bus that was deployed in Germany, and this bus goes from town to town where there's no longer a fully fledged medical clinic, but people still live there. And what we learned from this is that if you bring healthcare to a specific location, people are more inclined to go visit the healthcare spaces. And this is also what happened in South Africa. There was a train, and in South Africa, what happened was their local healthcare infrastructure wasn't good enough, and a lot of people were not getting the healthcare that they needed. And what happened was they got the funding for this train, and it would go from location to location and service the people who needed healthcare over there. And in the time that it's been running, they've managed to reach.
Them talking. So I think this is it.
Sorry, can everyone hear me? All right. So it was based in South Africa, and in the time that they've been running, they've reached over 23.5 million people. And what's cool is that people who live near clinics come to the train when the trains reach their city so that they can visit the train as opposed to their own clinic. So you can really see the power of mobilizing healthcare spaces. And here's another example, which is the Rambam Medical Center in Haifa, Israel. And this medical center actually has an underground car park that can convert from a 1,500 car capacity car park into a 2,000 bed emergency hospital within 72 hours. Now, this hospital came about after the Second Lebanon War, and as a result of that war, they wanted a space that people could rely on in case of an attack again. Now, this other healthcare space was Rush University Medical Center. This was brought on by the 9/11 attacks, and the United States wanted a facility that could be dynamic, and it could pivot and change the operating of the facility depending on the kind of emergency situation that needed aid. But then if you notice, all of these types of mobile healthcare spaces, they have a few things in common. Jess, would you like to explain more?
Sure, yeah. Thanks for that. I think we've seen even a new example just in the last 24 hours where they're talking about this field hospital that they've set up in the showgrounds, which they're planning to use for people in Melbourne that are needing to be tested and who are sick, to take the load off other local hospitals. But yeah, so we was thinking about all these examples and how they can be themed in the different dimensions that they're adaptable. So I think these 4 dimensions help us make sense of the ways that these healthcare spaces can be designed to suit new situations. So the first one being this isolation ability, obviously our made up term here, but basically the idea that you can have a health space where you can separate people if they're contagious, such as pandemic situations, or you can take away that separation and have everyone grouped together if you need a different kind of care. So having that flexibility to either isolate people or not, and then calibrate ability, which is referring to the purpose of the health space. So there's a big difference between, for example, an intensive care ward and an emergency unit. And so switch between the uses of those healthcare spaces is really important. And I think the the medical centre using the car park does this really well because they have a lot of their infrastructure built into the walls, so they can actually care for patients who are requiring intensive care, as opposed to more of the field hospitals that are more like triage or emergency. Then accommodatability is to do with number of people. So what's the capacity for that hospital space? So obviously the NHS Nightingale was fantastic because it had the space for thousands of beds, as opposed to some of the smaller medical centres and this new field hospital in the showgrounds, which is designed for 30 people. So adaptability in terms of the number of people they're able to treat is really important. And then also coverage or coverability, as we've got here, is about mobilising and about whether the healthcare space can cover enough area to suit the need. So to do with geography and the population. Gobin, did you have anything else to add to your summary before we talk about this a little further?
No, I think that's enough from the slides for the moment. Can everyone see me again? Right. There we go. Hi. But yeah, so from all these examples, we could see that there was something that happened, such as the Rambam Hospital with the bombs that occurred in the vicinity and the Rush Medical Center with the 9/11 attacks. There was something that happened, and the medical center or the dynamic health space was made in response to that happening. Even the title of this talk, it says looking at the learning from the pandemic and looking at the future. Nicholas, could you tell us more about what kind of thinking is this?
Hi, Gobin. Hi, everyone. Yeah, well, the thing is that from the initial introduction you made, speaking about how the health system have become rigid, the idea there is that how are we planning for our healthcare systems? And the usual way to do it is just by inductive reasoning. I mean, we see how things have worked in the past, all the different patterns we have been seeing, the different trends. We try to discover different causes and try to derive from them different effects. So this kind of inductive reasoning takes us to try to prepare healthcare systems that are ready to solve things that we have been seeing in the past. That's a kind of very common way of reasoning and has some different issues that, well, you maybe want to talk about them, Gobin.
Yeah, I wanted to talk on the drawbacks of inductive thought or shortcomings of inductive thought. So inductive thought, from what you've shared, it happens when I look in the past and something's happened, and then I think about what you call it, risk analysis, or scenarios where something wrong could happen, and then I create systems in place to avert that risk. But the shortcomings I see coming out of inductive thought is that they're always based on what's happened in the past before. And how do we overcome that problem and think of things that haven't occurred in the past before?
Well, that's a tricky question, and I guess that you show us before a great way to see how we can try to solve this problem. I mean, it's not a solvable problem; it's a very long-term issue that has been around us for a long time. But the thing is that what happens when you find a very unexpected event? That's when this kind of reasoning gets disrupted, because if things continue the same trend that has been occurring in the past, then you don't have any trouble. You prepare your system to react to that problem. In the past, for example, if you are designing a healthcare system that is very prone to tackle, for example, diseases that are not infectious, for example, I don't know, chronic diseases, for example, you don't need a lot of beds in the hospital.
but suddenly you get a pandemic and you need to increase your capacity in a matter of days. So when these sometimes rare events, very improbable events happen, you need to be prepared for that. Or not prepared, but to be prepared to do something with that. And that's what we are trying to, I guess that the example you showed try to make us think about how can we do this preparedness in some way.
Also, I just, because I have a background in data science, so I just remembered there are implications for inductive thought in AI as well, especially in health systems. When you train an AI model, there are two types of training. You have supervised training and then unsupervised training. The thing about unsupervised training is that you feed it historical data and the outcomes of the historical data, and you're then trying to project what's going to happen based on that historical data as well. And this is similar with sensors people can wear on the body. You can use heart rate data. You can pick all sorts of different types of data and do supervised learning like that. The thing is, any sort of biases that are not taken into account when you're doing supervised learning, you have this same sort of inductive problem, even within other aspects of the health industry. And one of the phrases I hear when people talk a lot about inductive reasoning is a black swan. What is a black swan?
Well, that's a good question because
Lenny, I see you laughing over there. Would you like to share a bit?
Yeah, I've had this conversation with a few different groups now about the black swan and how it's actually, in many ways, it's used for, I'm increasingly feeling that it's used for people as an excuse for not having a broad enough perspective. So if I've got let's say I'm a hospital person, I've got a very operational perspective, I know my history, I look at that, people call it a black swan event, and you go, well, actually, if you'd stood back and looked at emergent conditions, if you'd been looking at maybe global trends, you would have seen, you would have at least known that it was a possibility. Where the black swan event, the guy who wrote the book used it, and even his example is actually quite fascinating because black swans have been in the world forever, but he ended up in a part of Europe where it only ever seen white swans, and when he saw a black swan, he was surprised. And you go, well, so the whole black swan thing is actually, I think, a little bit showing lack of perspective rather than sort of thorough analysis.
Yeah, totally.
Exactly. But I mean, you mentioned the book, and Taleb, who was the one who wrote it, is actually giving a lot of interviews now saying this is not a black swan. I mean, this is white swan. We have been, I mean, the probability of having a pandemic event is not low. And a black swan, for the ones who don't know what this is, has basically three main characteristics. It's a very improbable, unlikely, and unexpected event. It has huge dramatic consequences. The other characteristic is that after the event, people try to rationalize it and say, okay, yes, we could have previewed this. So we could have expected this. And the case with the pandemic is, I mean, it's not like a tsunami that just happened. Pandemics are kind of events that throughout our history has been affecting people, affecting society. And the fact is that our healthcare system should have been prepared for this.
Yeah. So that what is it about? I know you mentioned Nassim and Nassim Taleb's book, and he talks about anti-fragility in there. What exactly is anti-fragility and fragile systems?
Well, basically, also for those who don't know this, Taleb, the guy who wrote this book, comes from finance, so some of his approaches are not exactly easy to translate to other aspects of life. But this concept tries to show how increasing risk can affect systems. So when you have escalating risks with very exponential consequences, negative consequences, the system breaks. So that's a fragile system, a system that is afraid of or dislikes volatility and unexpected conditions. While the term of anti-fragility, which is a term that actually doesn't exist in English, he invented it, talks about systems that thrive in this kind of context and improve and are better in this kind of context. So it's not merely robustness or resilience, which one is prepared to resist uncertainty, and the other is one to prepare to come back from uncertainty, but just to anti-fragile systems, try to improve in these conditions, basically.
Yeah, nice. So you said a fragile system is one when exposed to volatile behavior, the potential for harm will increase. And so when we relate that to our health systems, because they are they're solidified in their current styles of running, would that make them a fragile system?
Well, in some sense, it is the case because, for example, when you have a healthcare system that cannot increase its capacity quickly when it's necessary, and for example, when you have 10 people going to a hospital and they can't get the attention they need to get, it's okay. But then if you have 1,000 people going there, it's something that you cannot cope with. So if we can, at the moment, the majority of our healthcare systems are not prepared to cope with this kind of changing situations.
Yeah, so that one of the dangers in fragile systems is that the magnitude of an event and its impacts, they're not linear, right?
Exactly.
So if I have 5 people come into ED and the hospital can cope, but then if, say, 100 people come in at once, it would, the impacting factor just increases non-linearly.
I think we see that in the data for the case fatality rates in countries where the hospital systems are not coping, because in where you do have adequate healthcare, the case fatality rate is fairly low, like 1-ish%, or even less in Australia by the looks of things. But then in countries that are overwhelmed, the percent of people who get infected who die goes up, because you don't have enough capacity to be caring for each person as much as you would if there was less people. So I think we see that effect in the data for sure, in this situation at least.
Nice. So let us try to figure out how do we create an anti-fragile system within healthcare? What is it? What are some of the things that we need in healthcare that creates this dynamism?
I have a suggestion on this about the difficulty with creating anti-fragility in terms of experimenting. And I think we've mentioned this a little bit in that healthcare, it needs to be low risk. A lot of the ways we do things have been developed to minimize risk, and often they seem a bit old-fashioned, but they've been used for years and years, and we've taken the lowest risk measures possible, but it's hard to change those because it's hard to experiment, hard to try new technologies, it's hard to try new methods. You can't try them on people or in healthcare systems. So you need sort of experimentation for healthcare happening that is then somehow translated in. And I think there's a bit of a gap there at the moment. We have a lot of, startups, technologies, people like us talking about new ways to provide healthcare and create better systems, but then getting that change into hospitals and clinics and things like that is the big challenge. So I think experimentation in a system sense is really hard to integrate. Anyway, that's my That's my one thought, but I'm sure there's ideas for how we can do it better.
Yeah. No, I'm glad you shared that thought, because my line of thinking was extremely practical. I was like, in my head, I was thinking, okay, if I want to increase turn my car park into another sort of ward, can my digital infrastructure handle this new set of digital devices that we have running out there? But then what you said also, it occurred to me that whether we want anti-fragility or whether we want robustness in our healthcare systems, what we need, and this ties back into our code that we started with about adaptability, is to have dynamism in all our healthcare systems, and to sort of embed the concept of dynamism from the get-go, from building the infrastructure up. And one thing I think you mentioned a couple of days ago was passive infrastructure.
Yeah, in reading more about how it's called the reference architecture for technology in hospitals specifically. They refer to both passive infrastructure and active infrastructure, and they're sort of separate. And the passive infrastructure, I was thinking about an analogy for this. If you think of a hospital like as a person, the passive infrastructure is like the nervous system. It's the cables and fibers that connect all the technology together. So it's the hardware that's built into the building that then allows information to flow between areas. And so that kind of infrastructure is planned into the building. It's very hard to change quickly, but it carries the capacity. And then the active infrastructure is like your nose, eyes, ears, mouth. That's the technology you can see that people use to input information. So it's the devices, it's the phones, it's the equipment that monitors people, and that infrastructure is quicker to change. There's a lot of innovation going on in active infrastructure like technologies, but you can't support a lot of new active infrastructure if you don't have the passive infrastructure already there. So that, I think, is the main message. Like, if you think of it like the body again, you can't, like, if you don't have your nerves sending your messages to the brain, you're never going to smell anything, right, from your nose. Yeah. So I was thinking it like that. Bernie, did you have something to comment?
Yeah, just a couple of observations. When people are designing hospitals, really there's a lot of financial systems thinking that is really overriding that. And if you observe public hospitals in particular, they really try and run right up to, they're not really run as systems in the way you're talking about. They really are running to full capacity. So they really don't have the time to be thinking. They're not really an organic thing, because they're ignoring a lot of the dynamics. They're actually running them at max, even if that means putting patients in the wrong areas, all that sort of stuff. They don't really build in this extra capacity. I mean, because they argue and debate with themselves from a financial perspective, and it's always a real tension not to be investing too far ahead from political cycles. Current CFOs don't want to be investing for years and years ahead. So that's been coming back. So I don't think there is the flexibility built into the investment system. And then the other thing is that actually, if you spend $30 million on an IT system that's actually now about 4 or 5 generations out of date, you probably only depreciated it down to 15, 20 million. There's a lot of those financial things that are actually make it a very rigid, it's not a
totally. Decisions are made on money. I understand that, and a lot of that passive infrastructure is so expensive. Obviously, no one's going to be investing in for situations like a pandemic where they think, oh, it's not likely to happen in the next 5 to 10 years. But I guess that's this whole conversation is how do we
So-
have that in the plans, you know? Yeah.
So there's an example of where they have done a bit of that. So last year or so, I was doing a lot of work in South Australia, and the Royal Adelaide Hospital, they overinvested, quite frankly, is how, like, in all these sort of single rooms, and there was a lot of tension over that when they started operating. They were running well above the national efficient price, but they actually, now that the COVID thing has hit, they're actually arguing that it was a whole heap of foresight, that they've actually got the best designed public hospital in Australia. So it's interesting how even from a political and economic point of view, the debate goes around at different times.
Yeah, totally. Thank you for sharing that. And, you know, something the metaphor that appeared in my mind when everyone was talking is a bit like an iceberg, and active infrastructure is like the little tip that we see, and there's a whole host of other things that happened underneath that need to be there. Without it, you know, we won't even see what's on top. And then, you know, the other thought I had occurring in my head as I watched everyone on my screen right now is that it's a bit like a movie. We see the actors and the scene, but then what we don't see are the costume designers, the directors, producers, the years of practice that went into producing it, the soundstage managers and all of that. But yeah, anyway, I wanted to thank everyone for coming here today. And I was wondering, before we end, are there any questions or strong voices that wanted to be heard? Any final remarks? No? All right. But then just before we close, Rachel, one of our storytellers and journalists at the Guardian, she recently, not too long ago, she released a piece on the Guardian, I believe. It was
The Age?
about either the Age or the Guardian. It was about people who spent long periods of time in isolation. And when they came back, one of the questions she asked them was, what was the one thing that you noticed? And one of them said, I noticed how quickly I forgot the ordeal. And that's something I don't think we can afford to do with this pandemic. And so we really have to, as this is happening, even though it was not a black swan event, which is debatable, keep picking up all the lessons that we can and start putting them into practice. But yeah, I guess that's the end of OLO number 3. If I've said anything to anyone that they didn't like, I apologize. And for any mistakes I may have made, I do apologize as well. Thank you, everyone.